Good morning and good afternoon and even good evening to everyone. Thank you for joining us today for our new solutions for ultimate patient care webinar presented by one of our key opinion leaders, Dr. Chorak. Before we begin and introduce Dr. Chorak, I'd like to mention that this webinar will be recorded and available on our Schein Orthodontics website at henryscheinortho.com 1 week after today. Also, if you have any questions for Dr. Chorak, we kindly ask that you please submit it through the questions section of the GoToWebinar, which we will receive, and then at the end of the webinar, answer if time allows us. Now, everyone, I would like to introduce you to our distinguished speaker for this webinar, who earned his Bachelor of Arts from the University of Washington in 1995. He went on to graduate from the University of Kentucky College of Dentistry with high distinction in 1999. He then earned his certificate of orthodontics and dental facial orthopedics from the Oregon Health Sciences University in 2001. Throughout his schooling, Dr. Chorak earned numerous honors and awards for his excellence in research and academic achievement, including being a finalist for both American and international patent awards in dental research, and was one of the few students inducted into the National Dental Honor Society by Omicron Kappa Epsilon. He has published articles from the American Association of Dental Research, the Journal of Clinical Virology, and Orthodontic Perspective Innova. Active in the orthodontic community, Dr. Chorak has served as a secretary, vice president, and president of the Washington State Society of Orthodontics. Further, he has lectured on and was a focus group member on self-ligating brackets and class 2 correctors. Let's give a warm welcome to Dr. Mario Chorak.
Well, thank you, Ben. Appreciate the introduction. Want to say thank you for everybody who is attending. We got some crazy stuff going on here in Seattle, Washington right now. So I really appreciate you spending some time with me. My kids are out of school now until April 26th. So we're trying to figure things out and trying to figure out how we can keep everybody busy, but safe during these crazy times. So first of all, I was asked to give a presentation today on kind of the secrets and sciences that I kind of consider for passive self-ligation. We're going to talk about initially all the tools and resources I learned throughout the years from some incredible orthodontists that kind of guided me to produce great treatment outcomes and in a timely, efficient manner. And then we're going to talk about how the Motion Appliance has really changed the way I practice orthodontics in combination with passive self-ligation and the SLX 3D bracket. We're going to go in a little bit more detail to that. First of all, we're going to start off by just basically, so we're going to talk about, so I grew up here on Vashon Island, which is kind of in the Puget Sound area, just about 15 minutes off of Seattle there, down in the little bay there, Quartermaster Harbor. You can only get there by ferry. Went on to the University of Washington where I received my undergraduate degree, right there in the heart of Seattle. And there I met my wonderful wife, Marilyn, who she's been with me for 23 years, will be 24 here in June. And then we traveled to the University of Kentucky in Lexington, Kentucky for dental school. While we were there, the Cats won 2 national championships back in the Patino and Tubby Smith era. So yeah, if you love college basketball, unfortunately with the NCAA's being canceled, I was really getting geared up to watch some basketball here in the next couple of weeks. But great experience there, great school, learned a lot, got me inspired to go into orthodontics. We had a great second year class there that really kind of inspired me to go into ortho. I came back and I did my ortho training, like Ben said, at Oregon Health Sciences. We called it the dental school up on the hill. It's no longer there. I actually built a brand new school, dental school down by the Willamette River there. And they have a tram now that take you up to the medical institute up here on the hill. But great experience there, very highly clinical experience there at OHSU. Loved my time there, really enjoyed the faculty and my classmates that were there. But this is where I practice. I practice 2 little suburbs outside of Seattle. You know, don't come to Seattle now. Apparently, I think they might do a self-quarantine of the the state of Washington here. I think that might be what we might be hearing here shortly later this afternoon. But when all this is done, come up here to Seattle. August and September are usually the months when you're usually going to experience the most sun. So, but great city. We got Mount Rainier in the background there. At nighttime, we have amazing, basically cityscapes of the city skyline here. That's the Space Needle in the distance to the left there. And these are my two families here, and I consider these my two families, and basically in the sense of these are basically your two families. My family on the right, that's my wife Marilyn, my son Mason, and Julia. You'll see them a little bit later in the presentation. And this is my orthodontic family on the left here. This is our new office here on Mercer Island. So we've been in this facility now for about 3 years. We're looking at something in the middle of our waiting room that would kind of stand out. So we ended up putting a pretty large fish tank in there, about a 15-foot cylindrical tank there. And it's been a great little icon of the office. We take our real D-band pictures usually in front of it. So it's been great for the kids. Kids love fish, and apparently it's supposed to put everybody at ease. So, but that's kind of our new office now on Mercer Island. These are my two amazing assistants. So Sarah has been with me for about 18 years now, and Jill has been with me. So first of all, we're going to talk a little bit about self-ligation mechanics. Then we're going to talk about the mechanics involved with the 3D motion appliance. I know there are people who are listening who have done both of these, and so I'm just going to give you what I've learned over the years and just how we pair the two together and the concept of better together. So these are the two individuals that really inspired me to start using self-ligation mechanics and self-ligation about 15 years ago. So two of the original pioneers, I believe, of the system. So we have Dr. Damon on the left there, who created the system, and then Dr. Tom Pitts, who has really taught the doctors how to use the system, the intricacies and the secrets behind self-ligation, how to finish your cases. Both gentlemen I hold in high regards. And then we have this gentleman here who, if you never have heard Dr. Carey speak, very passionate about what he does. He saw some of the pitfalls like I did in some of the bracket designs, and he, with Henry Schein, kind of started the process of developing a new passive self-ligation system, the SLX bracket. And that, in combination with the Motion 3D appliance, has really created some game changers in our office, and I believe in the orthodontic industry. So when we talk about self-ligation mechanics, we're going to talk about the use of simultaneous mechanics rather than sequential mechanics. And what I mean by that is when we look at aligning the teeth, leveling the bite, AP correction, smile arc correction, transverse arch development, finishing, when you look at with self-ligation, all of those things you're looking at the initial bonding appointment. So all the things that we look at as far as AP correction, and you'll see that with sagittal first, but when we look at smile arc creation, where we're placing the brackets, are we inverting brackets? Transverse development, are we placing the brackets in the posterior teeth to give us that nice development? And then when we look at the finishing, we always have to think about where we want to place those teeth, where we want those teeth to line up at the end of orthodontic treatment, but we're placing the brackets in a position at the beginning of the treatment to give us that final outcome. So we've heard of this little acronym, this PRACM acronym. So it's basically progress, reposition, access, case management. So about 6-month procedure, usually about that 4th appointment, we'll take a progress panel just to evaluate repositioning, see if we need to do any repos, any repositioning of brackets, but we'll also assess the case management. Are we proceeding on extraction? Are we looking at the axial inclination, the incisors? All these things, are we getting, too much proclination that initially we were borderline extraction, non-extraction? So we're assessing all those things, seeing how all those things play, and then we're adjusting our case management if need be. So these, I believe, the 14 keys to case management are really key. I review these case management keys usually once every couple of weeks at the beginning of the week, just to see if I'm following all this protocol. So I love this quote from Aristotle: "We are what we repeatedly do. Excellence then is not an act, but a habit." I truly believe in that. We always shoot for 100%. We always shoot for excellence. We always try our best, and there are always certain factors that don't allow us to get there, but at least we're trying to get there. So when we look at key number one, positive and negative coronoplasty. So when we're looking at that, we're looking at the teeth. Are they worn? Do we need to do some initial buildups to place the brackets in the correct position to give us the desired outcome? Or do we have very large tips of canines where we need to actually go in there and do some enamelplasty and reduce those so we get the brackets in the correct relationship to give us that canine guidance and also give us a correct torque on those teeth. Smile arc protection, we've all heard this. I believe in passive self-ligation. When we look at that, we're looking at basically the slot of the first bicuspid, and when we were to draw an imaginary line out to the central incisor, that should be at that same level. And we'll take a look at some of the patients when we go into there, and we'll kind of see those things. Torque selection. So sometimes you'll hear doctors talking about inverting brackets, when to do that, when to invert brackets, maybe 2 to 2 on the anterior. We'll talk about all those things. Early light, short elastics. You'll see there, when to do that. Why are we doing that? We'll talk about those things. My biggest thing that I see from doctors who are attempting to use self-ligation and have difficulty, this is the primary reason, is we're not disarticulating the bite. So we're not using bite turbos or occlusal pads to help the effectiveness of the light rubber bands when we're doing that. But I also believe disarticulating the bite, you'll see in a future slide here, that gives us kind of starting the engine of the passive self-ligation system. We need to disarticulate the bite to have these wires work properly. And then if we look at arch wire selection, we're talking about controlling the axial inclination, when to use certain wires. We'll talk about how the SLX bracket, how it's kind of incorporated and really reduce the inventory of wires that we need. Look at 7, patient motivation. So this is a very, very, very big thing in our office now that we're using the Carrier Motion Appliance. And motivation is everything with these young kids. That's one thing I love about the Motion Appliances. We're doing these huge bite corrections initially when the patient is most highly motivated. And really, really we're becoming cheerleaders in our practice where we bring pictures up, we show the kids and the adults as well, where they started, where they are now, show them progress, just to keep them involved and to keep them motivated. And we all know that certain people can have certain habits, tongue habits, sleep disorders, finger biting, all these things, thumb sucking, finger habits. So we always want to diagnose those properly when we're doing our exams. Like we talked about before, number 9, repositioning brackets after a progress panel. Like we talked about, assess the case management. At that point in time, if we have a borderline case that was extraction, non-extraction, and I tell this to the parents, is that, if we look at that and we love how things are moving, let's keep moving that same direction. But if we feel like we're getting too much proclination, then, we can always take teeth out. I always tell that to parents, there's always a time to take teeth out, and that's a great time to assess that situation. Arch width adjustments, so for cross bite correction, a lot of times when we get into our finishing wires, what we call our M3 wires with the SLX 3D bracket, we might have to do a little bit of expansion to the upper wire, or maybe a little bit of constriction to the lower wire. So we're assessing, how the case started, how, what we're doing to finish these things. So we're looking at those arch wire coordinations very, very carefully. Overcorrection, and just like we were taught in residency, when we start overcorrecting with our elastics, we want to also overcorrect with the motion. It's very important with any type of elastic wearing appliance that we do overcorrect, because we're going to get a little bit of bounce, and we'll show you those cases, just how much overcorrection we like to get in our office. CR to CO shifts, make sure that the patient's in the right bite. We always evaluate that before we remove our motion appliance, just have them relax their chin, relax their jaw, and we'll just check that to make sure that we're not getting a slide. Microaesthetics, I think this is one of the most important things when we're getting close to debonding the case. We want to make sure that, not only the hard and soft tissue, but we want to make sure that the embrasures, the connectors, the chips, the dings is what I call them, that we smooth those out. We really produce not only great alignment of teeth and a great occlusion of teeth. We also want to make sure they look nice as well. So we do a lot of that in our office. We'll do a lot of gingival recontouring. Usually if it's a gingival recontouring, I'll wait maybe a few months after the tissue has kind of self-healed, and then we'll reassess. Two size refinement, I think this is very important too. And if we're not doing it as orthodontists, the general dentist will. Checking the occlusal adjustments. We have marking paper towards the end of treatment. We'll have them slide into excursion movements, and then we'll adjust. We'll do a little equilibration just to get their bite dialed in there. So that's kind of the 14 keys there to case management. Now we're going to talk a little bit just on bracket placement principles. We're going to go through these things very quickly, but I want to just it's very important when we look at the anatomy of the teeth that we're placing the brackets in the correct relationship to get the outcomes we want. So when we look at the facial axis of the clinical crown, we're going to look at FA point. Everybody's heard that kind of point before. Maxillary bracket position, mandibular bracket position, bracket placement principles, and talk a little bit about disarticulating the bite. And I'll show you the rubber bands that I use. I thought that was very important. I added that into this presentation so we all kind of have an idea of what elastics I'm using, once we're out of motion and when we're into the SLX 3D brackets, how we're getting these bites to kind of dial in there. So when we look at the facial axis of the clinical crown, what we're going to look at here is basically it's a line, except for the molars. It's the most prominent portion of the central lobe. So when we look at that, I think a really good guys, if you look at the gingival aspect of the tooth, if you were to bisect that, and draw the line all the way up, that's usually going to give you the facial axis of the clinical crown. We look at the buccal groove. You see the buccal groove basically separates the two halves of the teeth there. And then if we take a look, we're going to look at basically the FA point. So the FA point is it's the point on the axis there that separates the gingival half from the occlusal half. And that's what we call the FA point. So when we look at first molar placement, when we look at the upper, what we're looking at, basically the slot of the bracket should coincide with the FA point. And basically you want an equal amount of the mesial and distal cusp showing when you're doing that. And that usually will get you in the right orientation. You look at the very, very point of that gingival embrasure. That's a really good line when you're bonding to take a look, make sure the slot is even with that. And that's what I usually will use as another marker. If we look at the second molar, we want to make sure that's just a little bit more occlusally oriented, just so we don't get any hyper occlusion in the posterior there. The only time I ever will bond it a little bit more gingivally if the second molar hasn't fully erupted. So just, take a look at that. Sometimes on your steep mandibular plane angles, you definitely want to bond them a little bit more occlusally. On your fives here, basically it should be even with the slot of the 6. We don't have any marginal ridge discrepancies. Same thing, look at the slot of the bracket, should be right at that kind of apex of the gingival embrasure when you're kind of rolling a line that's even with that. One thing about your upper fives is just remember that the facial axis of the clinical crown is usually positioned a little bit more mesially. So I have a lot of people when I see bonding, usually the 5, when they put the 5 on, it's not bonded enough mesially to help with that rotation and making sure that it's in the proper place. And then when we look at the 4, we want to see a little bit more of the occlusal half of the clinical crown. So you kind of take a look, it's even with the 5, but you can kind of see we see a little bit more of the occlusal surface of the 4 than we do of the 5. And that's usually a perfect placement of the upper maxillary posterior teeth. Here, if we take a look at the slide here to the right, you can kind of see we're seeing more of the clinical crown on the 5 than the 4. So you see we actually have an open bite developing there. So that's improper placement. So you can kind of see the difference there. The diagram shows a really well placement of the on the left-hand side there, second bite, first bite. So we just always want to make sure when we're looking at those things that we should see a little bit more of the clinical crown, the occlusal portion there on the 4 than the 5. Mandibular bracket placement is a little bit different. So if we have ideal overbite, basically when we're looking here, you got the slot of the bracket going right through the FA point. Everything usually lines up pretty nicely there. Same thing in the incisor area, normal overbite. We want the slots there right at the FA point. Basically, if there's no enamel attrition, basically you should see an equal amount of the base of the bracket to the incisal edge. Same thing on the canines there. So basically, when we take a look at smile arc protection, so when we're looking at this, when we're looking at the occlusal plane, usually gives us a pretty nice smile arc. So if you can kind of take a look at it, like I mentioned before, if you're drawing a line through the slot of the upper four as you're going more towards the anterior part of the mouth, that line is going to basically give you an idea of where that central incisor bracket, the slot of that central incisor bracket should be. So when we're looking at that, you just basically want the upper laterals to be basically, I like to go about 0.5 millimeter less than the centrals, and then the laterals about the same as the canines there. So that's usually what I usually like to do, but everybody varies a little bit here and there. And we got to look at the anatomy of the teeth as well. But from a central standpoint, that's usually what we'll do is we'll kind of figure out where that lies, we'll measure it, and then we'll go 0.5 millimeter less on the lateral, and then either, and usually that will be probably about the same as the canine there. So we've seen some of these things, the green zone, basically. So if you're to measure, let's say you determine that the maxillary central should be at a 6, then we go 5.5 for the lateral, and like I said, 5.5 for the cuspid. So at least way back in the day, when I was taught orthodontics about almost 20 years ago, we were told to fix these deep bites, you would position the upper incisor brackets more incisally. Well, you would fix your overbite for sure, but it would bury the upper incisor up under the lip. And what we're seeing now is that we would age those patients pretty dramatically. So we want to kind of create a workflow, basically trying to create where we're going to place the upper incisor bracket, and basically at desired the maxillary incisor position. So when we look at ideal maxillary incisor display, so when the patient's showing, we're showing the ideal gingival display, the ideal maxillary incisor display. We basically want to position the upper and lower incisor brackets ideally, okay, incisal gingivally. Position the lower incisors more incisally if we have a deep bite, and gingivally on an open bite. So we're going to basically kind of keep the upper incisors where we want them in the ideal position, but we're going to really address the lower arch when it comes to deep bites, open bites, and all these things. So excessive maxillary gingival display, though, that would be the one position where you actually would bond the upper incisor brackets more incisally. So that's the one case where you actually would do something like that. Insufficient maxillary incisor display, obviously we're going to position the upper incisor brackets more gingivally. We want to show more display. And then basically on the lower, we just want to position them in a way that's going to idealize the overbite. Flat reverse smile arc, very similar situation. We're going to position more gingivally, and then we go 0.5 millimeter less on the laterals, and same thing on the canines. So here's an example basically for a patient who has a very deep overbite, and we take a look at the lower arch here. So we're going to bond the posterior brackets more gingivally, and then we're going to bond the incisor brackets and canine brackets a little bit more incisally. So you're taking the curve of Spee out of the lower arch by positioning the brackets in the correct position. And then when you put a straight wire in, we're going to get intrusion of the incisors and some extrusion in the posterior segments there. So same thing for basically an open bite tendency. We're going to bracket the brackets above the FA point in the posterior and below the FA point in the anterior. So similar situation, we're going to get some extrusion in the anterior segment, some intrusion in the posterior segment. So this is one of the things that I love looking at. I love this slide here because it explains basically why sometimes passive self-ligation mechanics don't work. And really the biggest reason why it doesn't work is we're not doing this very simple step where we call disarticulating the bite. So my assistants know that in our office, even if they're not occluding on the lower brackets, I do some form of disarticulation in our office. So everybody gets some form of disarticulation because I want to get these light wires, these wires that work in a range of 120 to 180 grams. kind of that starting process to get the alignment going. You know, our bite forces, our occlusal forces, you know, they range anywhere from 40 to 50 pounds. So if we're not disarticulating the bite, if we're not creating a little bit of bite opening there, then we're not going to see the movements and the degree of movements and the quickness of the movements that we should see. So disarticulating the bite is very important. What we do in our office when we first get started, even if it's a deep bite, deep overbite case, we will actually bond occlusal pads in the posterior on the usually on the lower sixes or the upper sixes initially, and then we'll start moving the disarticulation more anteriorly. So sometimes we'll move them on the canines, sometimes you'll see some on the centrals and some of the cases that we'll be showing. But it's really about disarticulating the bite and really learning how to use these light elastics to your advantage. So speaking of elastics, we're going to talk about the elastics we use in our office. So I use a couple of these elastics, it's 1/4 inch 4 ounce and a 1/4 inch 6 ounce. I use those for my shorty elastics in the posterior. So if after the case is done and we have a little bit of a lateral open bite due to the molar pads, we've taken these things off and we're going to start some light elastics. So we're going to start doing some posterior eruption, and so if they have a little class 2 component, we'll go from the upper 4s to the lower 6s. Vice versa, if they have a class 3 component, we'll go lower 4s, upper 6s. That's how I usually like to run them. And I'll usually start off with an Elliott. I used to use a Pete elastic, which was a 3/16 2 ounce. I just feel like it's easier for the kids to hook these guys up. You know, it's not necessarily we're wearing these things full time as well. Sometimes we will prescribe it full time just to get that posterior segment established. The Fred elastic there, the heavy elastic 1/4 inch, I'll use that for a cross arch elastic. So if we have a upper 6 to lower 6 cross-bite tendency or cross-bite relationship, we'll disarticulate the bite in the posterior using molar pads, and I'll have them wear like a sidekick or a Kaplan hook from the palate of the upper 6 to the buckle of the lower 6 to get those bites to jump. This elastic, this 5/16 2 ounce elastic, I like using this elastic after the patient has gone through Motion Appliance. If they're class 3, we'll hook it up from the lower 3 to the upper 6. I'll usually have them wear this thing just at nighttime, just to tether the response. I don't want to lose any of the correction, or if I've overcorrected, I don't want to lose any of the overcorrection. So we'll do that. We'll instruct them to wear it just at night if necessary. These other 2 elastics, a little heavier, so the 5/16 4 ounce and the 5/16 6 ounce. So a lot of times when we're entering into our M2 wire or 20/20 copper night tie or 19/25 copper night tie, or the M3 wire, the 19/25 beta, we'll use these elastics to finish the case up, whether we have a class 2 or a class 3 component. A lot of times I'll use the Louis elastics, the medium size and the rectangular night tie wires. We usually won't go into the Roger until we're into the finishing wires, the M3, the beta titanium wires. And then here we got bummer elastics. So we're going to take a look at these guys and the bills. I don't very rarely use bummer anymore in my office. I don't feel like I need to anymore now that we've incorporated the carry motion appliance, but I have it if in case I need it. Bill elastic, I really like this elastic for our aligner cases. So this is a 3/16 4 ounces, a really nice elastic. It gives you that enough of that force level, but it won't dislodge the aligner. So it's a really good one that we've been using in our office. So now that we've gone over kind of what the armamentarium that we use, and we've talked about disarticulating bites and elastics and bracket positioning and all those things, I'm going to show you some examples. And I just wanted to show you some of the things that we do in our office and how we go about constructing these cases. So when we look at that first image on the left there, we see what I was taught is we look at the incisor that is the most displaced, whether it's gingivally or facially. And what we're looking at there is we're basically determining is the lower incisor in a good axial inclination, or do we need to guard against proclining the lower incisor? So You can do it two ways. You can just go in there and open lightly with a light open coil spring, and we'll do that on an 014 or 015 wire initially. Half a bracket, not more than a half a bracket activation, to just start creating some space. So if you had teeth that were a little bit retroclined, little incisors that were retroclining, and you were doing this, then I don't think you have to do what I'm going to show you here in the next slide. But what we ended up doing is we proclined a little bit of those lower incisors just by going in there and doing some light open coil spring. But you can kind of see the health of the tissue with self-ligation. You know, we don't have to round trip teeth anymore. Here's another example of controlling axial inclination. So we take a look at the upper incisors here. We've got some retroclined upper incisors. You know, we construct the case. We're making sure we guard against over proclining, but we want to get those teeth a little bit upright. So bracket positioning is key on these cases. If we take a look at here, note the overbite correction, but also note that we didn't correct the overbite by placing the upper brackets more incisally. So we still have it where we want, and we're still getting overbite correction, because you'll see here in a second, we actually bracketed the lower incisors more incisally, and we disarticulated the bite, and we have the patient wearing some light elastics to get the posterior to erupt. So we take a look at that upper. If we look at the upper four, we'd look at the slot there, or draw a line straight across. You can kind of see that is even with the slot of the central incisor. And then the lateral and the canines are positioned accordingly to give us that nice smile arc. It's just a progression here, spike correction. So here's another case here. So in this case, we actually did open up space for that blocked out lateral. And you can see sometimes we'll even ligate the wire. This is a little bit larger wire, but sometimes we'll even do this on an 015, where we'll actually just take a lace tie and ligate the wire, not into the slot of the bracket, but just around the bracket. And that gives us a little tether as well, so we don't overly procline the lower incisors. Same thing here, you know, we're guarding against axial inclination. This patient here has a blocked out canine, so we're working on just creating space, retained primary C there on that upper right. But back at that last slide, notice the arch development that's occurring, and you see this all the time with passive self-ligation. You get really nice arch, you know, development of the arches when the lateral bone support is there. So this patient, that's always what I'm looking for, is how much lateral bone support do they have? Do they have enough to treat the case non-extraction? You know, those are all the things that we're looking at. We're not growing necessarily new bone, but we're utilizing the bone that's there to our advantage. So we take a look here. So same thing, things are lining up. Upper four, the slot of the bracket of the upper four in line with the central there. Here's another patient here, upper twos and crossbite. I wanted to show you this slide because this is the time when I like to invert a bracket, just because I like to bring the root actually facially and not have to do a huge root bend, a huge torquing bend at the end of treatment to get that in a correct spatial relationship. So we take a look at here. We're going to do some disarticulation in the posterior. We're going to make sure that we don't bracket those brackets too incisally. We want to make sure that you'll see here that I bracket them actually fairly gingivally. And on her case, I didn't like the proclination on those upper centrals as well. So I actually inverted 2 to 2 on her. But you can kind of see just in 6 weeks, you know, by disarticulating the bite, we got the bite to actually jump on her. And now we've got, just in a very, very light wire, you know, we've got that crossbite corrected. And then you kind of see here, you know, we're guarding her smile arc. We don't want to overly intrude on her. Another similar situation here, we have minimal gingival display upon smiling. So you'll see here how far gingivally I bracketed these brackets, and especially for these blocked out canines. This is before I was using Motion Appliance. I just want to kind of show you what we can do from a spatial relationship and a space creating relationship if we're doing it, if we're guarding against putting too much open coil spring here. So what we ended up doing here is we inverted 2 to 2. We bonded very gingerly because I really wanted to control those axial inclinations as we're making space for those canines. That's what we do. If we want a little rotation of the upper sixes and we want to kind of just work on maybe getting a little distalization mechanics there, what we'll do is we'll leave the wire a little bit long distally to the sixes. And we've got some open coil, not more than a half a bracket, creating room for the upper fives and then creating room for the upper threes. So we do very light activation. As that molar rotates, it may start to may have that wire getting short in the posterior. So we just need to kind of reassess that. A lot of times I'll use a, sometimes I'll use like a 19 by 25 copper night tie with this, with what we're doing here. Sometimes even a 17 by 25 copper night tie. I don't like to necessarily use pre-torqued wires because I just think inverting the bracket's a little easier and it reduces the amount of inventory that you have to keep. But here you kind of see the upper twos kind of in that crossbite tendency, and the threes are blocked out. So you can see where we are here right now. So I probably could have even bracketed those incisor brackets a little bit more gingivally. And that's kind of what I'm looking at right now to get what we needed to get here. But you can kind of see we're making progress. The threes are incorporated, the fives are coming in. He's a little class 3 in the posterior. We're going to work on that with some elastics. And I think I did actually get a repositioning appointment on him. I think we repoed 3 to 3 on top just to get a little bit more, gingival expression. Max just finished his treatment here last week, so I'll get some progress pictures here next time we give this presentation. But you can kind of see we've really guarded the axial inclination, and that's really just from bracket placement. Sometimes what we talked about, inverting brackets will give us that desired outcome. You can kind of see we got literally all the teeth now in, so he's looking good. I don't know how you guys handle teeth that are rotated at 180 degrees, but I usually will just kind of place the palatal cusp buccally and we'll leave the buccal part palatally. So that's kind of how we handle Max and fit in there great. So you can kind of see we've really, from the time that he started and where he is now, really changed that. And like I said, I know we repoed him 3 to 3 to get that canine socked in and actually get a little bit more incisor display. So we've got more tooth there to play with, which is great. So this is a case that I just wanted to share with you, case that transferred into my office. And I know we always have challenging cases, and when I look at this case, I think it's very challenging from a whole bunch of different standpoints. But one, you have, it's like you got a posterior crossbite present there initially. Obviously, you got midline discrepancies, you got class 3 profile and a class 3 malocclusion. And you've got very, very, very severely proclined teeth on the upper arch that you can see, and you have crowding. But the biggest thing that I see here is you have literally no lateral bone support to play with here. So when I see cases like this, and I didn't have the patient's headphone, but when I see cases like this, I think of there is just no way I'm going to make this case any better by not taking teeth out. Sometimes passive self-ligation users, they get beat up because they call them non-extractionists. Well, if a patient like this presents in your office, believe me, there are times to extract teeth. And I would have definitely taken teeth out on this because these were his beginning records. The next picture I'm going to show you is where he came into my office. So this is where he appeared in my office. So you can see just by putting brackets on, disregarding axial inclination, disregarding the lateral bone support, this is what can happen with passive self-ligation in a hurry. If you're just going to go slap brackets on and not follow protocols on passive self-ligation, you're going to turn a case that, and I believe that should have been extracted to where you didn't have to round trip the teeth, to a case like this where you need 4 bicuspids out and some serious anchorage in the posterior to upright these teeth. So he wasn't very happy to hear that, but that's what I suggested. And that's the problems with not learning how to use self-ligation mechanics properly is you can get cases like this. So I hope the things that I give you here, and I'm going to show you some cases where you know, give you all the pearls that I know that I've learned, how we don't do something like this, but we do something like I'm going to show you here in the next slide. So, because it's my daughter, we're going to see how I treated her. So I'm going to give you a little scoop on Henry Schein Orthodontics, and I'm really sad because I was going to give a 4-hour presentation on self-ligation mechanics at the symposium, and if you guys haven't heard yet, they actually canceled that event. So I'm going to show you what the brackets, how they're made. You're going to see a little video here, and then we're going to kind of go into detail on what I love about the SLX 3D bracket.
Schein is validating themselves as a company to me and as a partner in my practice simply because they're willing to improve something that's doing very well already. And not only are they doing the SLX 3D system in metal, they're also proposing that they're going to do it in porcelain. Every one of my problems in my practice, because I haven't had a really good passive self-ligation system to offer that's in a clear ceramic system.
So one of the amazing things about the SLX 3D is the manufacturing tolerances are unbelievable. Metal bracket and the ceramic bracket have been manufactured at the same tolerances, and the engineers have spent a lot of time verifying and validating that, so that if a patient decides that they want an aesthetic option, we don't have to compromise treatment results in order to achieve it.
We were looking for a simple way to open the bracket, a method in which the patient would feel least amount of force as we were opening and closing the bracket. We have integrated easy twist technology that with a simple twist of a tool, the bracket will propel to the open position. The heart of the patented technology of the SLX 3D is the 2 microsprings that are contained within the bracket. These springs interact with the bracket, creating a very consistent and repeatable open and close force. The clinicians gets a very positive feedback from the bracket when it is either opened or closed using this technology.
It's a bracket that will be able to fulfill the demand of those patients that are asking for aesthetic treatment. But at the same time, we will be able to make it shorter, easier, and with high precision.
To me, the SLX 3D is the culmination of efforts of a number of different people. I'm not talking just about the Team Schein members. I'm also talking about the clinicians from around the world, leading orthodontists that have experience with new product development. And we have assembled this team of employees, of clinicians, of engineers, unlike anybody has ever seen in the orthodontic industry. And it's a powerhouse team that comes together to deliver these fantastic treatment solutions for customers and for their patients.
Well, I hope that came through. I did not hear any audio on my end, so I hope you guys got some audio there. But we're going to talk, I'm just going to burn through these a little bit quicker, some of the reasons why I am now exclusively using these 2 brackets in my office, and to show you from a design standpoint why I think it's the best one out there. First of all, we're going to look at the actual bracket. Some of the biggest things that I like is their redesign on their new bracket. It's very smooth, smoothest bracket I've seen out there. I love the fact that the actual door covers the entire bracket. So unlike competitors out there, you'll see that the door usually sometimes only covers 1/3 of the slot of the bracket, but these doors actually cover the entire bracket. Love the easy twist tool. They have redesigned it, so I'll show you the redesigned instrument here, which is amazing. You're not going to have initially when the clear brackets came out, sometimes we were getting some breakage, but we have not gone any with this new tool. So I'm going to show you some of the things. The hooks are great. They're integrated with the bracket. They're fairly smooth. They're not big or bulky or pokey. So we'll talk a little bit about that as well. But like we talked about, the full mesial distal coverage there, it really, really helps you get those rotations out, allows for the alignment of the teeth to occur very, very fast. And then it keeps the rotations held corrected. So that's one thing I love about it. Here you can see a bracket on the left, which is basically covering maybe 1/3 to 2/3 versus the one on the right, which is the SLX clear, covering the entire face of the bracket. The one thing about passive self-ligation, and I think Henry Schein hit a home run with this, is they have two size specific brackets because every tooth isn't the same mesial distal width. So when we look at the centrals and the cuspids on top, they're a little bit wider than the laterals on the upper, and then the bicuspids have kind of a medium width. So the nice thing about that is you get teeth that basically line up quicker. You get ideal in and out rotations corrected, and you get torque expression that really holds and treats out very nicely. So we don't really have to bend a lot of wire anymore due to the, like we talked about, the torque values, the in-out dimensions, the thickness, and the slot depth. So when we go through the progression of the wires and we talk about the M-series wires, you'll see that most of these wires are specifically designed with this bracket in mind. So we talked about the smoothness of the bracket. Let's talk about the profile of the bracket. So, so the clear and the metal are designed exactly the same in the sense of the overall appearance of the bracket. And we take a look, it's literally from what I've seen, it's the lowest profile self-ligating bracket on the market. And that's so important from breakage, from comfort to the patient. But we really have seen hardly any breakage from a D-band standpoint with these brackets. We talk about some of the things with the base. So we have basically the micro etch pylons for the metal, and then we have the mushroom pylons for the clear. My girls say it's the easiest ceramic bracket that they've had to remove in the office as far as the clear goes. But we have the when we talk about the guardrails. So when you see that on the brackets there, when you put the adhesive on, you press on the tooth. Most of the adhesive actually goes mesial-distally instead of incisal-gingivally, so we don't have a lot of flash that's left at the gingival margin or at the occlusal there. So fits great, comes off very nicely. So when we take a look at here, we got the hooks. You can kind of see designed for comfort. Comes actually off the bracket, so it doesn't go very high. So it's curled as well, so you get really nice comfort from the patients, and I usually talk about that. And this is the one thing I really like. They got away from the paint lines, which is fine. I'm okay with that, but they still have the horizontal and the vertical marks. And basically, when you look at those two lines, when they meet, that's where the FA point is. So two very distinct lines. Also with the clears, if you have difficulty seeing that, if you look at the mesial and distal wings of the bracket, that will also sight you down the FA, this facial axis of the clinical crown, and then just look at the middle part of the bracket will give you that where that FA point is. Talk about the twists. We're talking about no pulling. Originally came out with this instrument here, but now we're moving to this one on the right, which is autoclavable. It has a little metal tip, and you can use this in the clear and in the silver. I've tried it in both. It works fantastically well, but this is what we're not going to have anymore. We're not going to have the instrument going into the slot of the bracket. So we have this little metal tip. Yeah, the instrument won't be able to get into the slot of the bracket, just the tip. And as you push the tip there, you just do the twist, and then all of a sudden the door pops open. So no more being able to get in there and dislodge doors or anything like that. So fantastic generation. Mark Payne and the crew down there did a wonderful job of giving us an instrument that is now working beautifully. People ask, can you have colored ties with the SLX 3D since it's such a low profile bracket? And absolutely. The ties that we really like to use are the safety ties that you see on the left there. Henry Schein has these. I think it's ortho organizers there. You can get your catalogs, but they come in all different multicolors. We are placing these on our patients if they want colors. We only do colors 3 to 3 on the upper if they want it. And then they do have a continuous chain, which has been working great in our office. We use this one. If you do want colored chain, I recommend the continuous Rocky Mountain chain. And I do believe ortho organizers are working on their color chain as well. And as soon as that comes out, I'm going to get that because it's fantastic chain. We're really liking it. These are how the brackets come, and they come in totally different. You can get them in sticks of 10 with the metal, or they come in these individual kits. Just like we talked about, some of the reasons I really love it: profile of the bracket, 2 size specific. I love the vertical and horizontal hashes of the bracket. Just a really nice design. Here they are in the clear. And just like we talked about, some of the biggest differences I've seen with other self-ligating brackets is, it's a lot of the other companies out there, either the slot size is too big, the mesial and distal dimensions are all the same, the teeth aren't all the same. The profile on some of these self-ligating brackets are very high. With the SLX 3D, it's very low. And the base of the bracket just seems to fit the teeth very, very nicely. So we're going to talk about wire sequencing. And when we take a look at that, today there's so many wires to choose from. Everybody's looking for a system, which sequence to follow. So many wires out there. One thing I like about is there's really no guesswork when you're using the Motion Appliance. You use a Force 1 or Force 2. That's pretty easy to remember. And same thing with the SLX 3D brackets. When we're talking about why the M-Series wires are a perfect match, they specifically designed the wire to fit in the slot of the bracket. So you get accurate, predictable torque expression, and you get ideal tooth positioning and alignment and leveling of the arches there. So we're going to talk about the wire sequencing. These numbers are thrown out there: 3 to 6 months, 8 to 10 months. There's so much variability with treatment timings, but I will say it's produced the concept of sagittal first incorporation with the SLX 3D and the wires has really reduced the amount of treatment time, but also just being more efficient, being more predictable, having everybody in the office know kind of which wires and what sequencing is used. It just created a very, very nice seamless system in our office. So here we have the M1 wire, which is an 015 copper nitai. We got the M2 wire, which is a 2020, and the M3 wire, which is a 19 by 25 beta titanium. Now there are some other wires that sometimes we'll incorporate. Usually the 2020 to the 19 by 25 beta might be a little bit of a big jump, so we'll use what's called an M5 wire, which is a 19 by 25 copper nitai. And here are the different wires here. So sometimes this is the M series is what we see up top there. Optional wires, we have an M1 wire or M15 wire, which is an 018. So sometimes we just don't get all the rotations worked out in that 015. Sometimes we need to engage the 7s. We may have a little bit longer span there. So sometimes we'll use that 018 and then the 19 by 25 copper nitai. I recommend this wire for any of the ceramic brackets before you go into your beta titanium wire. And I don't necessarily need this, but sometimes maybe you need to get a little bit of arch expansion. You're just not able to get it with that M3 wire. Sometimes you might need a stainless steel wire as well. So these are the different wires that we talked about here. Talked about inventory management, office communication, and just having a protocol in your office, to make you more efficient, more standardized. And these are the different wires that I use in my office. So we'll use an 015, sometimes we'll use an 018, 2020, 19 by 25 copper nitai, and then a beta titanium. So space closure with passive self-ligation. So I like a lot of the other doctors out there like to consolidate the anterior spacing. And then once you get the anterior spacing consolidated, a couple of different ways to close the posterior spacing. You can do what Dr. Carrier does, where he ligates from the 6 up to the 3. He doesn't like to put chain on his 6 because he feels like once he's got that class 1 platform established, he doesn't want to derotate the molar. So he'll run a chain from the 5-4 and then up to the crimpable hook on the wire. I've tried it this way and it works really well. You can chain 7 to 7 or 6 to 6, just personal preference. Sometimes we'll just make sure we back it up with an elastic if we feel like we're getting over rotation molar. But this is one way to do it for sure. You kind of see now that he's closed that space there. Looks really, really nice. So this case here, we're gonna get into some cases. We're gonna go pretty hard and heavy here. I hope some of the mechanics, I want to spend some time on the mechanics because I think it's really important. Anybody can show you well-treated cases and show you their best cases. I wanted to really kind of dive into the mechanics, talk about what's important when we disarticulate a bite, elastics, why do we use light elastics, all those things. I really wanted to dive into those things and case management stuff. But now we're getting into cases here. So I had this little girl I hold dear to my heart. This is my daughter Julia, and this is of course it's always your kid. You know, it's just one of your most challenging cases. But Julia came to my office at 10. She was eating a Subway sandwich, and we noticed that there was what we thought was bread at her gum margin, but it was actually her canine. So she loves having me tell the story. But so basically, I brought her in for an exam immediately, and we looked up there. Obviously, upper canines are blocked out pretty severely, as well as the lower. So we started thinking about doing possibly some self-ligation mechanics to start working on opening up some space for those canines. So just like we talked about on Max's case, what I did on Julia, I call it a self-ligation gainer. You've heard of other, people call it other things, but we inverted upper 2 to 2 brackets on her, and I put brackets on the 6s, and we did very light open coil springs from the 2s to the 6s and started moving those molars distally, consolidating the anterior spacing, and that's kind of what we did on Julia, upper and lower. And this is where we got in 12 months. So, we started creating space for the canines. We still are blocked out on top, kind of controlling that axial inclination. So that's why we inverted the brackets. And like I said, moving very, very slowly. 9 months later, you can kind of see one canine starting to poke through, the other one's still blocked out. But the lower arch, we made everything in the lower, and the one thing that Julia had going for her is she had amazing lateral bone support. So we talk about that, always looking at the lateral bone, the extent of the lateral bone support. I always pay attention to that, determining how much crowding we have, how much proclination we have, and determining, do we need to extract or not extract. So those are really the things that I'm looking at. With Julia, I saw that we had plenty of lateral bone support, and but still tough. I mean, that upper left, I gotta really work hard to get that sucker in. So, but here she is, pretty much class 1 canine, right and left, class 1 molar. So here she is. So we got her in there, full decal in upper right 3. Yeah, we all have those patients, even our own kids. So, but we got her in there 13 months later. One thing I always note about self-ligation, and I look at cases a year out, 2 years out, is Julia still has lateral bone support, and we're able to fit everything in there. But one thing that I always notice with the cases is the health of the gingival tissue. When we're using these light forces, we're really just not overly exerting a heavy force on the tooth to get it to move. And Julia is a prime example of that. Here she is. Look at the gingival health, class 1 molar and canine, socked in there, no recession. I gave this same talk and same presentation on Julia to a periodontist who literally thought we're going to have to graft the lower right canine. And so I said, well, if we need to graft it, great. But I still think, didn't warrant taking 4 teeth out on this girl. So here she is here. So you see no root resorption, teeth are nicely uprighted. Everything's, relatively good balance, facial balance. Those are the things that we want to look at too. So here she is 2 years later following ortho treatment. You'll see it's got a beautiful, nice, full smile there. Kind of see, nothing's moved, everything looks really good alignment-wise. Gingival health, you kind of see here in the buccal segments, everything looks really, really nice on her. 2 years out of treatment. So just going to recap here. So here she was, 3 months for her phase 2 treatment. Take a look at the gingival health. Here she is 1 year out. Didn't have this picture, but here she is 1 year out. And then we take a look at here, 2 years out. Bites settle in there nicely. So protocol that I use in my office, we do a bonded 2 to 2 on top, lower 3 to 3, bonded just to the canines. And then we do that the day of debond. After that, I usually will see the patient back in a week. We'll take impressions or scan for SX retainers, and then we'll see the patient back in 2 weeks. And that I like to do that because we can get a little bit of settling that occurs before we have to put these patients in SX retainers First 2 months in my office, we have the patient wear it 2/3 of the day. So I don't have them wear it outside the house. They come home from school activities or come home from school. We have them place it in there, wear it after dinner and sleep in it. After 2 months, I have them wear it every night. And then after the year, we have a talk. Patients want to take the retainer out. Then basically what we will do is if the patient wants the upper bonded retainer removed, then we'll remove it and put them in an upper Essex retainer. So we follow our patients for a year. So we do a 2-month, 3-month, and a 6-month check. Here's Julia, 3 years out. Everything's still looking great. This kid's a great patient. She wears her clear retainers now probably, I would say once. She probably wears it like twice a week at nighttime, 2 or 3 times, yeah, somewhere around there. So they still fit great. So I wanted to show that case because I really wanted to show people that you're not dehiscing roots, you're not creating a bunch of recession, especially if you go slow and you'll learn how to use the mechanics correctly. 4 years out of treatment, she looks amazing. So here's another case. Patient comes in. Patient literally brought her son in for an exam, but I looked at this patient and I said, would you like to go through treatment? She had Invisalign, wasn't a very good wearer of her appliance, and said that she wanted something aesthetic, but she only wanted to be in them for 12 months. So I had the SLX 3D clear bracket going, and I asked her, as I go, well, I'll go as fast as I can. And she's like, she held me to it. This is an ENT doctor, very, very opinionated, and we just kind of went at it and tried to give her the best result we could. So this is where we started with her. We've got class 1, canine and molar. Obviously, we got procline incisors. So what I ended up doing is I inverted the centrals on her, and basically we started just lining things up. The one thing you saw in her initial picture, I actually ended up opening space for those blocked out incisors on the lower. I just did not bracket her straight from the get-go. And then we laced back. I wanted to control her lower incisor inclination. But you can kind of see how the teeth are lining up here, really taking advantage of her lateral bone support. This woman's got a ton of bone support and really didn't like her narrow arches or narrow smile. What I did for her too, since she had that incisal chip, I did a little bit of composite bonding on those centrals just to make that look really nice for her. Once we started lining up the teeth, you could actually see the chip a little bit more prominently. But here she is. Just to give you a recap, remember where she started. Here she is 6 months into SLX 3D, and here she is finished 12 months later. So fast, easy, effective. I kind of say that, in roundabout terms, but literally just moving through the wires. For Lisa, we basically went 015. I think I did do an 018 just for the ceramic, 2020, 19 by 25, and then got her into finishing wire, 19 by 25 beta. But she's got nice broad arches for him. We really kind of worked on controlling axial inclination. She's super happy. Loves the composite that we did for her, and has referred several patients to our office. So now we're going to talk a little bit about motion. I just wanted to kind of show those first 2 cases, and we're really going to dive into the SLX 3D bracket after this. So basically, the biomechanics with the Motion Appliance. The one reason why I really, really, really love this appliance is you go after patients when they're most motivated, most cooperative, and most compliant. Versus at the end of treatment where you're trying to really get that last millimeter of correction and they're just burnt out, they're done with it, not cooperative, not compliant, hygiene's becoming an issue. So I love going after the hardest part of their malocclusion right from the beginning. And when we look at what we're doing, so when we have cases that have excess overbite, crowding, rotated molars, what we see here in our office, and we'll see this as quickly as the first appointment. Sometimes it takes a second appointment, but we'll see, molars rotating distally and uprighting. We'll see the premolars moving, and translating posteriorly. We'll see spacing between the incisors, so we get that interceptal spaces occurring between the incisors. And we'll take cases that normally would have been extraction cases and make them non-extraction cases. So these are some of the things that you should see. You should see this in one appointment if you have the patient changing their rubber bands regularly. And what we do in our office for adolescent patients, we have our patients changing these at least 4 times a day. So after every major meal, we have them change them after breakfast, lunch, dinner, and right before they go to bed. And we'll usually see this by correction within 6 weeks. I start off with a force 1 elastic. I always go, if the canines are present, I always go from the 3 to the 6. If the 7s are present, I love to get on the 7s, always for adult patients. For adolescents, the 6s are fine. And we'll go 6 weeks. If we get correction, I'll assess. Sometimes we'll go into that force 2 elastic, that second appointment. But usually in that, we do 6-week intervals. So in that 12 weeks, you might be corrected or overcorrected. And then we'll start taking the patient as a reward. We'll say, okay, you did such a great job. We're going to now have you wear your elastics just at home. So we'll do a 2/3 wear for 1 appointment. And we'll assess to see if we're getting a little bit of bounce to the bite, or if it's staying corrected or overcorrected. And sometime we'll do maybe just nighttime wear for 1 appointment. So on a compliant patient, you're in and out of this for anywhere from probably about 4 to 6 months. If you want a skeletal correction, I usually will go 6 months with those patients. So you can kind of see here, there's been some research as it helps, airway issues. Remember, picture in time, that's what we're looking at here. So that's what we're looking at. I know it helped my son dramatically, who was a snorer, and so we'll show Mason's case here in a little bit. But these are the things that we should see. So, we see, rotational control of the molars, uprighting. I think, having that, having the motion appliance, the bar kind of creates a little bit of a buccal shield. So you do get a little bit of expansion with the appliance. The premolars move distally, but they also move a little bit laterally as well. And then obviously you see the spaces that are created between the 2s and the canines, and sometimes you'll even get spontaneous alignment of the upper incisors. A lot of times on those DIB 2 cases, you'll get uprighting of the incisors. So those are one of the reasons why you really don't need a high torque bracket when it comes to the SLX 3D if you're using motion. But these are the 3 highlights that I like to talk about, the advantages of the motion, and really the time in braces or aligners significantly reduced, and that's super true. And you'll see that here when we show the cases. But I also think the number one most important thing is the patients, they see their overbite, they see their overjet being corrected right at the beginning of treatment when they're most motivated. So they're realizing, the importance of the appliance and the importance of wearing the rubber bands. And we've just seen a huge increase in our annual starts. So same day starts, how we handle those in our office, we patients ready to go, we'll do an initial scan for the appliance. So if we need upper Essex on a class 3 or lower Essex on a class 2, we'll scan for that. I have my local lab who's given me a great deal on manufacturing these. They'll make 2, and plus we have the model. And I tell the parents that, now that we have 3D printing and all that stuff, we have the model on site, so we can keep that while the patient's going through treatment. So if they happen to lose, let's say they lose both their Essex retainers, we have the model, we can make it on site for them. I don't want that to be a deterrent for them not going through treatment and not using this appliance. So that's what we do in our office, and it works out very, very, very well. I'm gonna burn through this video. So we're gonna show some patients now that basically that I've used where we used the motion appliance initially, and then we moved into SLX 3D brackets. So when we take a look here, so we got Jackson here, obviously, class 2, we got some anterior crowding there, deep overbite, lower midlines off to the right by 2 millimeters, and then we got a pretty substantial amount of crowding there. So this is what I'm talking about as far as overcorrection. So this is basically the day that we bond the brackets. I wanted to show bracket placement with this picture, but I also wanted to show you how much overcorrection you can get with this appliance. So you remember where Jackson was initially, that's how much crowding we have, that's how much crowding we have now. So we've gotten some spontaneous alignment. Obviously this kid did a wonderful job and, overcorrected dramatically. I like my overcorrection where I like to go with the appliances. I want the upper canine, I want the cusp tip of the upper canine touching the lower first bicuspid. That's kind of what we're looking at here. So you accomplish that in 5 months. So here we are, 4 months of SLX brackets. So we can kind of see we're starting to, you overcorrect a little bit of posturing there. We've got them on a light elastic now, like a 5/16 4 ounce class 3 elastic being worn at night. So I'm just starting to tether that occlusion back. And here we are. So 1 year of total treatment, SLX brackets for 6 months here. He's doing a good job here. Now we're gonna just work on that anterior occlusion. I think I did a little repositioning here at this appointment. Yeah, and here we are right here, just finishing things up, getting that posterior occlusion socked in. So he's been in treatment now for 17 months. I think we just got his finishing wire here, and he's just about done. This is a whole different animal here. So when we look at Sierra here, we can kind of see we've got that canine that's severely blocked out on that upper left side, class 2 molar end on both sides. So what I did here is we did a standardized motion on the right, and we did a shorty on the left. For shorties, I basically will do a shorty anytime a canine is displaced too far gingivally, too far palatally, or too far facially. So there is a need for a shorty, but if the canine is in a pretty good position, I like to always go after canine. I think it gives you a better vector and it gives you a better bite correction as well. So here she is, 6 months of treatment. So look at the space we created on this girl here. So we got, now we're gonna go and basically construct her. I'm gonna stay off the 2 and I'm going to go after the 3. So here we are, 6 months of treatment. She's got beautiful, beautiful bite correction here going on. And here she is. So patient's been in overall treatment for 12 months, so 6 months of motion, 5 to 6 months of the SLX 3D here. Now you can kind of see here, now that we've got the canine into that class 1 platform on both sides, patient still has the upper right E present, but now we've got space to bring that lateral forward, and you kind of see I inverted the bracket. So I wanted to show you this case because I just took pictures on her just this week. And I wanted to show you how fast his tooth came forward. So literally we went from here. I took pictures because I wanted to get an idea of show you how just creating space around the E created the 5 to come in as well. But here she is here. So here she is. So 8 months of SLX 3D brackets here. I mean, note the bite correction, note the gingival health that has occurred, but look at how the laterals come forward very nicely. So we just moved into a 20/20 on her today, or this last appointment when I took these pictures. So, yeah, but positive profile changes, note the alignment, the occlusion that's established here, note the health of the patient there, the gingival health that's occurred. Here's another one here. So here we got a class 2 to 1. Look at the overcorrection that we've established here. Look at the bracket positioning. So sometimes you'll get if the patient's really wearing this well, they'll give you a little bit of a reverse smile arc. So you just gotta make sure you bracket for it correctly, because you'll go from here. Here she is. She was in her carrier for 4 months. I mean, here she is. So 9 months of total treatment, 5 months of SLX. You can kind of see the bites just socked in there nicely. And then here we have a class 2 div 2. Second opinion, patient was told she needed a Mara. I said we had a different appliance. So patient just did exactly what we asked her to do, lower Essex. We bonded from the 3 to the 6 here, but look at her profile. Look how retroclined those upper incisors are. Here she is, 6 months into treatment. Look at the profile change. Look at the uprighting that's occurred on those upper incisors and the space creation. And then here we are here, just 6 weeks into treatment, just lining the incisors up here. So we put an 015 in there, took it all the way, I believe, to the 7s on her. But look at the profile changes that we're getting here with Alyssa. And here we are, 12 months treatment now, 6 months of SLX 3D. You can kind of see just how things are lining up. The alignment looks great. Now we're going to work a little bit on. So initially I had molar pads on the 6s. Now we're going to move them up. I think we're going to place these on the canines here. You'll see a picture. So when I do that and we start working on the vertical part of her bite, that's when we're going to use those little shorty elastics from the 4s to the 6s and start working on closing that posterior bite up. And you'll see that here in the next picture. So here we are. We've got We've got bite turbos on the upper threes. You can kind of see now we've got that posterior occlusion socked in right and left. And then I believe at this appointment we took off the bite turbos, and then I think we got her into her M5 wire 19 by 25 copper. So she's just about done. But so we've been in treatment for overall 15 months, 9 months only in the SLX 3D brackets though. And look at the positive changes we've made for this girl, you know, on a non-grower too. I mean, it's just amazing when you start unlocking these bites, you start lining these teeth up, just the response you get. Here's little Miss Anna here. This is a case where I did a shorty on. Great case. People always ask, you know, do you correct the crossbite first? Do you do sagittal first? And this is a case where she was only in crossbite on that 6 on that upper right side. And what we did on her is we did a molar pad on the excuse me, on the upper 6, and then we had her in a lower S6, and I did a shorty from the 4 to the 6. But you can kind of see this is where we got her when we took her motion off. So you can see the canines are in. So you don't always have to expand to get the canines to erupt. You know, the patient's class 2, you know, using a shorty and a patient who's class 2 dentally and skeletally, using a shorty there can get the canines to erupt. And that's what happened here with Anna. So 8 months in, you can see the 3s have erupted, overbite correction, crossbite correction, and then just great profile change on her. Here she is now. So now 1 year of treatment, you can see we definitely got her out of crossbite on that side. And now we're gonna work on, believe we kind of moved things on her, same thing that we talked about. We're gonna move those molar pads to the anterior, and then we're gonna get her wearing a little box elastic, or like I said, a little shorty elastic from the 4 to the 6 to get that posterior to erupt. Another case here, we can kind of see class 2 profile, 3s are blocked out. So, but the patient's class 2 molar and also class 2 profile. So I did a shorty here on Jasper. You can kind of see the overcorrection that we got here. Space creation for the canines. Everything's moving in great. Here he is. So 12 months total treatment, SLX 3D for 6. Same thing on Jasper. We're going to start moving things to the anterior. That's kind of what we have here. So you see the bite turbos on the upper 3s now, and same thing we talked about. We're going to work on a little light posterior elastic, and I usually will start it off full time, see how well they do. I explain to them they're changing that little posterior elastic 4 times a day. A lot of times they will get that posterior occlusion touching, and then we can reduce or eliminate the turbos in the anterior. But he's doing great. Hygiene isn't looking all that great, and we explained this to Dad, and Dad knows, and so we're on it. But you know, the nice thing is like, look at the profile change on him, look at the alignment, space creation that's occurred in such a short period of time. Some class 3s here. So Samantha case is pretty challenging because she's still in her mixed dentition, but she wasn't losing any teeth. So we knew we needed to do some. Her tissue was getting a little thin on those lower incisors. So we ended up constructing her upper arch, and I used a class 3 motion on the lower. And you will see when you use that class 3 motion, you will definitely change the occlusal plane, and you will definitely upright those lower canines, and they will get loose. You have to explain that to the patient, to the parent, so they don't freak out. But that's really what you're changing, is you're changing the occlusal plane on these patients. Sometimes if you have a class 3 open bite, this is what's happening. You're getting those canines to move distally, to erupt. I usually will do the same thing on my class 3s as far as overcorrection goes. I like to have the lower 3 touching the upper 3, and that's usually the overcorrection that I like to get on these cases. Here she is. So we took that off, and now we're working on just lining things up on her. Canines are coming in. Second molars are erupting. Here she is finished. You know, it took 24 months, but that's because, you know, she didn't have all of her permanent teeth in. But she's fitting in there great. She came in for a 2-month check, bite settling in there nicely. Super happy. Parents are super happy. And then we're just going to monitor her growth, see how she's growing. Right now, overbite, overjet looks great. Here's another case. Just thinking outside the box, you have a patient who's congenitally missing that lower left 5, and obviously, you know, we've got a little bit of an open bite in the anterior there, but she's class 2, and that's what I was looking at. So With Rebecca, we ended up going with the Motion Appliance initially. This is where she was. This is where when we got her out of her Motion Appliance, you can kind of see that open bite actually got a little worse. I'm not concerned, never ever concerned with self-ligation, because when we bracket her, we're going to bracket her in a way that's going to close things down. So here she is 4 months, and then here she is 3 months, 2 wire changes. Patient has now a positive overbite, class 1. Kind of see we're slipping a little bit on that left side, but we're going to capture that. She's got a wisdom tooth on that side, so we're going to use that. We're going to incorporate that. And then here she is right here, SLX treatment for 8 months now. Things are lining up great on her. She's just about done. Another class 3 patient here. We'll take a look at Sophia here. So we ended up doing, we constructed the upper arch, and then we did a class 3 on the lower. So here she is, 4 months. You kind of see how much those canines will erupt. Here she is 7 months with braces, 4 months in the class 3 motion. Here she is, so finished 18 months, total of 4 months with the class 3 motion, 14 months with the SLX brackets. And here she is 3 months out, so everything's still looking good, dialed in there with that class 1 platform. Another case here, slightly class 2, but did not like the proclination of the incisors and didn't like his excessive overjet there. So we ended up doing a class 2 motion on him. He got lost a little bit. I don't know if they were out of town for a while, but this kid overcorrected tremendously. I have colors on him because I wanted to show that you actually can place colors over these brackets. That was one of the reasons why he has some colors on these. Initially, the first appointment will go without colors, and usually that second appointment, once the wires have started working, we'll tell them that they can have colors. But we always explain colors as a reward system. We also explain colors can slow treatment down a little bit. So a lot of times patients hear, quicker without colors, and they're all on board. But here Matthew is here. So 12 months of total treatment, 6 months of motion. Notice the arch development occurred, reduction of overbite and overjet. He's got a little small over lateral incisors, and he's got some space here to get those aesthetically corrected if need be. And here's another one here, Carson, great patient. Was a little bit class 2 on both sides there. Deep bite, retroclined upper incisors. So here we was, so 6 months of motion, overcorrected him. Here we are in some SLX 3D clear on top, and then we got the 4s and the 5s with the SLXs. But kid, just two really great kids. His family is amazing. Mom was a little skeptical about the motion at first, but when she saw the correction that we were getting on both of her kids, she's been a huge referrer to the practice. But we take a look at, so this is where we finished. So 6 months of motion, 12 months of SLX clear, so 18 months total. But he's socked in there. Nice class 1 canine molar relationship. And these pictures I think were taken right at the day of debond. So I usually will take my pictures about 2 months at that 2-month retainer check, just so the tissue's all healed up. But great patient, did a great job. So I wanted to get through these cases first, because I wanted to show you how we're doing it now in our office with the SLX 3D brackets and the carrier motion. So when we look at the incorporation of the 2 appliances, basically what we've seen, and the incorporation of the M-series wires, we're basically, self-ligation has become much more enjoyable experience for me in particular. But I think my staff would also say they love the way the systems have incorporated, and our patients love it too, because they see, like I said, the hardest part of their bite correction is done initially when they're most motivated. We're seeing an uptick in our starts. And with everything going on right now in today's world, being efficient and effective and making it fast and easy for everybody, that can be very beneficial to everybody involved. So I know we're at the mark at 12:30. I do want to, if I can, I want to kind of burn through a couple cases and show you some particularly really difficult class 2 cases. So I'm going to see if I can get, I'm going to burn through some of these here. One of the things I just want to show you on this case here is this is what I use to determine where the kid is in their skeletal growth pattern. So have they reached their pre-adolescent growth pattern? So I learned this in my residency years ago. You know, when I first came out, I started using this to determine kind of where kids are in their skeletal growth relationship. So I can give you an idea of when's the best time to use the Motion Appliance for class 2 correction, but also give you an idea of if the patient has any existing growth left for class 3 correction. So that's kind of what you're looking at there. So we're looking at that CS3, CS4, we're looking at that C2 vertebrae. The superior part of the vertebrae should be flattened, and we should start to see some convexity or concavity on the inferior part. That kind of determines where the kid is in their growth spurt. And then as we get later, you see that those actually enlarge to determine kind of if the patient has stopped growing for class 3 correction. So I use that quite often. I want to get through some of these cases. I want to show you a couple really difficult high angle cases that we've corrected and we've followed. Sebastian's a great kid here. He just came in recently for some follow-up pictures. This kid's a troublemaker. This is my son Mason, but he's a highly let's see, he's a highly motivated kid to do well in sports. We're working on the schooling thing, but he's doing pretty good. But their entire lacrosse season got canceled this spring. I think most of the spring sports have been canceled up here in Seattle, in Pierce, King, and Snohomish County. So we got to find out what we're going to do with these kids for the next 6 weeks while they're out of school, and then figure out what we're going to do sporting wise. But Bass was a great patient, did a shorty on him. He grew tremendously. This kid is 6'3", 205 pounds, and he's only 14 years old. So real big kid, but look at the profile changes and the skeletal changes we got with him. Just all on treating him at the right time. We hit him at a perfect time when he was growing. This is a case I want to get through. If we can just spend a few minutes here on this case. So this is a really interesting case just because of how difficult, but how motivated a child can get to getting where they want with this appliance. But Claire came into my office, second opinion. Another orthodontist wanted to take out 4 buys, and you'll see how crowded Claire was. I mean, it could definitely warrant 4-buy extraction, but mom was pretty adamant, did not want to have teeth out. And this is a case where the lower lingual holding arch was there. I was just getting started using Motion, and I said, you know what? Why don't we just use the holding arch? Let's see what happens. Normally I would use an Essex retainer, but I used it on her, and I wanted to show you kind of what we got with her. So obviously severely crowded, severely proclined, and we've got class 2 molar relationship, end on, full cusp on that one side. But this is where we got with her in 5 months. So you can see the space creation we got with this girl. I actually did do it to the canine on both sides. May have not done that in today's time, but I did do it, and we got just amazing bite correction with her. If you look at the lower incisors, they stay relatively the same way. Lower 7s actually did erupt. But this is where she basically took that upper canine and took it into almost a full step class 3 molar on that right side, and then on the left side, similar situation. So this kid wore it super well. So we take a look at before and after motion, before and after motion. We take a look at here, look at the overcorrection we got. Look at the spontaneous alignment of the upper incisor. But look at the profile change. just going to kind of go through this. Let's talk about. Claire was really good. Her mom was awesome. She was so excited that we were treating her non-extraction that she let us take all these pictures on her. So we just followed her throughout the whole process. So here she is. So 14 months SLX, 9 months of motion, or 14 months total, excuse me, 9 months of motion. 9 months SLX, 6 months motion, yeah. And for Claire, it was, you know, she had enough lateral bone support that I thought we could push the limits. We had enough space creation with the Motion Appliance that I thought we were doing a great service to her. But for me, it was her profile was the game changer for me. I just thought, you know, we had a patient that was still growing, taking advantage of that. That's for me was what I was looking at. So this is where we finished her. I believe she was about 20 months, 21 months of treatment. It looks good. And then I want to show you, look at the profile change that we got on her though. Unbelievable. And that's really what you're doing with this appliance is you're literally changing the occlusal plane. And obviously we had some growth with her. We'll take a look at the Panorex, no root resorption. These pictures I just took on her recently. So these pictures that you're gonna see now, she's been out of treatment for 5 months. So we take a look at before and after. Here's a profile change. Here's the alignment, upper and lower. Here's the buccal segments. So just to recap, this is where she was post-motion. This is where she finished 22 months. And here she is 6 months now, 6 months out of treatment. But look at the gingival health. That's the one thing that just blows me away is that her tissue almost looks better out of treatment 6 months than it looked when we first started her. So just a great case on a high angle case. I know sometimes those cases are challenging and scary, but believe me, they can be accomplished. So anyways, I know we're going a little bit over, but it's been a great hour and a half for me. I hope some of this is beneficial and helpful for everybody that was able to join the webinar today. Ben, any questions?
There's just one question, so we'll just leave it at that. The one question that we have is there a specific tool for removing the brackets?
For removing the brackets, so what my girls use is they use just a pin ligature cutter at the base of the bracket, and that's all we use, just whatever we would use with any other bracket to remove. I don't use a special tool. I mean, Henry Schein probably doesn't want me to tell you this, but we're able to sandblast the brackets and reuse them on rebond appointments. We don't have any issue with that. Sometimes even with the clear brackets. So.
Okay. All right. Well, that's the end of our question section. Sorry for the ones that just came in. We will try to address them. If you can just send us an email, we'll also keep note of it.
Yes. Hey, Ben, if anybody's still listening, since I didn't get to the end of the presentation, I'd like to give everybody my email address. It's toothtwist@comcast.net. So TOOTHWIST@comcast.net.
Okay, perfect. And I'd like to thank you very much, Dr. Chorak, for spending the time with us to be able to share your wisdom and insight on how you integrate the SLX 3D and carrier motion appliance to handle these very difficult Class 2 and Class 3 malocclusion cases. Really enjoyed your presentation and your insight. And for those who are listening, we do have other events where you can meet Dr. Chorak in person, or meet many of our KOLs in our calendar. So please just check us out on our website at henrysscheinortho.com for a list of our events. And we thank you all for attending.
Thank you.